I'm Regina Smith. I'm Senior Services Manager here for West Tennessee Healthcare. And on behalf of West Tennessee Healthcare and our other sponsors for this evening, I welcome you. The purpose of tonight is to provide education and resources to those who have perhaps been recently diagnosed with Alzheimer's disease, their families and loved ones, and their caregivers. We know that you are facing a very long and tiring journey. We know that the road is going to have lots of turns and lots of detours, and we want to be the ones to help you as you face this journey that you are on now. I also want to let you know a couple of things that we have ongoing here at West Tennessee Healthcare before we start tonight. We have a support group that meets here at the hospital on the first Thursday evening of each month. And right in this conference area, Medical Founders Room A. We meet at 6:30 in the evening. We will have speakers and a time of sharing and caring for each other every month, and we would love to have you join us at any time for that support group. I think there's a flyer out on the neuroscience table, and you might want to pick one of those up and get some more information about our support group, because it is something that will help you as you face the days ahead as you're caring for your loved ones with Alzheimer's disease. We also, as I mentioned, we have a conference that will be coming up this year on February the 20th and 21st. This will be our 8th year to have Teepa Snow join us for our Caregivers Conference. If you've heard Teepa before, you know that she is phenomenal. She is a wonderful speaker, wonderful information, and great advice on caregiving, and the caring of those that you have in your family with Alzheimer's disease. So you will hear lots more about this conference in the days ahead. I would like for you to know that we have a website where you can gather more information about the conference and other activities, see some videos that we put together from our physicians at the Neuroscience and Spine Clinic, and some other information. And that website is www.westtnalz.org. So I'd encourage you to go to that website for more information after this evening, and hope that you will be helped by that information you'll find there. Tonight, I would like to thank again our sponsors, West Tennessee Neuroscience and Spine Center, Comfort Keepers, Tennessee Health Management, the Alzheimer's Community of West Tennessee, Alexandria Place, and the Foundation. Thank you so much to those sponsors who have helped us provide many events this year for those of you who would like to learn more about this disease. This time I would like to have Shelley Hayes come to tell you a little bit about our speakers.
Good evening. Welcome to West Tennessee Healthcare. I am the Corporate Health and Wellness Manager here at West Tennessee Healthcare, and we're so excited about tonight. We have some really great speakers. First, I would like to introduce Dr. Murray. He is a highly trained neurologist that completed a fellowship at Duke University School of Medicine. He has been a part of West Tennessee Neuroscience and Spine for the last 6 years. Dr. Murray grew up on a farm in Missouri. He is married to a beautiful lady, and they have 2 amazing children. Patients love Dr. Murray for his compassionate and for also the ability that he relates to them very well. So at this time, I would like to welcome Dr. Murray to the stage.
All right. Can everybody hear me okay? Okay. All right. There it is. There it is. Well, thanks for having me back. I gave a similar lecture like this last year. I did not just carbon copy the lecture, I promise. This is a little different. But I try to want to hit on the same points that we talked about even last year, and I put some new slides and some new information and such in. So kind of the whole point, why are we here? This is a situation that, as was mentioned earlier, a lot of families are dealing with, more and more families are dealing with. This is just kind of some numbers. I don't want to try to bore you with numbers, but it kind of shows the prevalence of memory issues, dementia. About 5.1 million diagnosed with Alzheimer's, with about a new case every 72 seconds if you break down the numbers. The interesting part about this too is there's some data that says about 50% of patients are probably never even diagnosed. And so there's a lot of patients in the community, in your church, in your small groups, whatever, that may be struggling with this and they don't even know it, or the families don't even know it. The key thing too, and the reason why a lot of people are here too, there's statistics that show probably about 10 million people or so in the U.S. are trying to care for a loved one that has some type of memory issue, sometimes a cognitive issue, which is a very taxing role to play that a lot of people are dealing with right now. So kind of what is my goal tonight? I like to kind of set out and say, here are the things that I kind of want you guys to get an understanding of, and kind of what our point is tonight. I want to talk a little bit about memory loss in general. Not all memory loss is dementia. We're going to talk about that. Typical evaluation for memory loss. So if someone comes into the clinic with memory conditions, memory issues, how do we work it up? Why are we doing certain things? Different causes of dementia. And then we're going to spend a good deal of time talking about Alzheimer's specifically, dealing with dementia. And I just put down here, if all of a sudden I start talking about symptoms of Alzheimer's and you're like, oh no, that describes me. I'm not trying to diagnose anybody. No, nothing like that tonight, okay? All right, so as I said earlier, not all memory loss constitutes dementia, okay? We get older. All of us do, okay? So one thing is, getting older, our memory does get a little bit worse, okay? And so there is what is called an age-appropriate memory loss. And so some patients come in who say, I'm having difficulty remembering this fact, I'm forgetting the names of these people, and you look at them, they're 85 years old. And it's like, look, for 85, this is not bad. And so there is an age-appropriate memory loss that does occur and is considered normal. It is somewhat dependent upon education level, and it's usually the extreme education levels. And so you would expect someone, let's just say with a PhD, to have a little bit better memory than someone with maybe a sixth grade education. So it's usually the extremes play a role. And so here this is talking about what are things that are considered normal memory loss, and what are the things that you hear and you're like, well, okay, that's probably considered normal. The reason is because also it's not just a cognitive issue, but you have decreases in ability to hear. You don't see as well. And so sometimes it comes across as, well, grandma doesn't remember. Well, grandma never heard you, or grandma didn't see well what you were showing, and so it comes out as a memory loss. General slowing of process information. People that get older don't process information as quickly. The thing is, too, intelligence remains stable. So if you really get them to focus, their intelligence is still the same. They still have the same intellect they had 20, 30 years ago. Maybe a little bit of a decrease in the ability to recall names of places, objects, especially things that they don't deal with on a day-to-day basis. The key thing is, down here on the corner, on the bottom, you can't see, the key thing that differentiates memory issue, like memory loss, from being normal memory loss versus a dementia is they continue to maintain independence of living. So they're not needing help with things like activities of daily living, general hygiene issues, which we're going to talk about later. So other causes of memory loss, we talked about age. Age is one issue. The other thing that comes up sometimes in the elderly are psychological issues. And sometimes these things can come out as memory loss. So things like depression, anxiety, adjustment disorders. I've seen several patients who have worked in the same job for 50 or 60 years, and all of a sudden they wake up one morning and they're retired, and they don't know what to do with themselves, and it drives them batty, and it comes out as memory loss. And so sometimes you have to look at the psychological side of things that can present in an atypical fashion, and their memory is fine. It's that they're dealing with a lot of adjustment issues. Sometimes depression, family strife can come out as memory loss sometimes. And then, of course, you have the dementias, which are a big component of memory loss. And basically what dementia means, the definition of a dementia, is memory loss that's not explained by age, affects activities of daily living. So you have some type of loss of function, and we're going to talk about that in a little bit. So that is the broad definition of dementia, and there are several different types of dementia. When a patient comes into my clinic or any neurology clinic, at least I'm not sure how other clinics behave, but in our clinic, the typical way you work up memory loss. Is this normal for age? Is this some type of psychological issue? Is this sign of some type of dementing process? How do you sort through these things? One is you get a good history. Do they have a history of significant strokes? Have they had a history of traumatic brain injuries? Has there been some type of brain pathology somewhere in the past that could potentially explain some of the issues they're having with cognitive ability? You do a neurological examination, do a physical examination, looking for any findings that would kind of point you in a certain direction. Laboratory testing, a lot of times the lab testing is done just to rule other things out. There's not a lab test that diagnoses dementia or clears someone from dementia, okay? Same thing is true with neuroimaging, with either a CAT scan or an MRI. CAT scans or MRIs do not tell you whether or not a person has a dementia or not. What you're looking for is some type of structural abnormality, and usually about one time a year in our clinic, one of us will stumble across some kind of benign brain tumor or something that's probably been there for 20 years. And it's finally kind of reaching a point to where the person's having memory issues. So this is why, so a lot of the lab testing, the scans, the images and stuff are more to rule other things out, not necessarily to diagnose dementia. A key part of sorting out, is this normal memory for age? Is this some type of psychological issue? Or is this truly signs of a dementing process? Is the neuropsychological testing. In our group, we actually have two neuropsychologists. One of them, all he does is testing for things just like this. So he's going to look at short-term memory, long-term memory, deductive reasoning, abstract thinking, recall, insight, all the things that kind of go into what's considered normal cognitive function. We all take for granted, but he has ways of breaking this down and saying, look, for someone with your age, someone with the education level, this is normal or it's not normal. But he also does a good job at screening for depression, anxiety, adjustment disorders. And so I tell patients, and some of my patients are in this room here, you may hear me say this, he helps me separate the wheat from the chaff. What am I dealing with? Am I dealing with someone who is just getting older and the memory loss is normal for age, but it's just bothering them? Do we have some type of psychological issue that we needed to address, or is this sign of some type of dementing process and we need to go down that road? So a very key part in trying to decipher out what this is or what it's not. All right, so let's go into the dementias. Okay, so again, these are the folks who have memory issues that are not explained by just getting older, not explained by some type of psychological issue such as depression or anxiety, okay? Again, the definition of dementia, memory loss plus an issue with either speaking or writing coherently. They have difficulty recognizing their surroundings. They're getting lost in their house. They can't find the Walmart that they've gone to for the past 20 years. I had a patient one time who showed up at church on a Thursday morning and thought the rapture had happened because there was no one at church. What was the wrong day? And this is the same. So things in the routine that all of a sudden, that become routine, all of a sudden become a problem. Have that with memory loss, you're entering into the definition of dementia. And again, what I say down here, issues interfere with daily activities and independence. Now, I use this because these terms get thrown around a lot. Dementia, Alzheimer's, what's the difference? So this is an analogy. I had this slide last year. I think it's a good one. So all pansies are flowers, but not all flowers are pansies. Same thing is true. All patients with Alzheimer's have dementia, but not all dementias are Alzheimer's. Okay, so Alzheimer's is by far the most common dementia, but you do have several different types of dementia. Okay, we're going to talk about those in just a little bit. Okay, so kind of just a clarification of some terminology. So what causes dementia? We're going to break this down into progressive dementias or dementias that are not reversible, and some dementias that actually are reversible. So of course your progressive dementia, the most common is Alzheimer's. Lewy body dementia is an unusual or fairly rare dementia that has a lot of Parkinson-like features. Typically these patients present initially with very vivid and oftentimes very violent hallucinations, which is very typical for an Alzheimer's type patient. So the presentation is a little bit different. They, again, can look like they have Parkinson's disease. They don't respond to Parkinson's disease treatments. And so that's kind of what a Lewy body dementia is. Frontotemporal dementia, I've actually got a picture of that here in just a little bit. Basically, the frontal part of the brain just begins to shrink up. And so a lot of times these patients have significant behavioral issues. They kind of lose their social graces, if you will. And these patients can be very difficult to handle. They're very difficult to handle just because, they've kind of lost that executive functioning, that those social graces that kind of keep us social. And they can say things that are completely off target. I had a pastor one time who all of a sudden started saying cuss words all the time. The guy couldn't help it. That frontal part of the brain that kind of controlled those socially inept things just was gone. Thankfully, that was kind of a rare one. Vascular dementia, hence the word vascular, patients who have repeated strokes. They have a stroke after stroke after stroke, and over time, you start losing real estate. That's the way I say it. The brain starts getting several different areas where strokes have occurred, memory issues become a problem. Typically, with these three, with Alzheimer's, Lewy body, frontotemporal, usually you kind of have a gradual decline. In patients with the vascular dementia, you have kind of this stepwise decline. They're doing fine, they have another stroke, bam, they're down to a lower level. They do fine, have another stroke, they're down to another level. So instead of kind of this just gradual decline like you have with most dementias, the vascular dementias, you have more of a stepwise decline. So that's kind of a difference between them. So this is an example. I'm not trying to gross you out. I know you guys just ate. I didn't realize they had food. Otherwise, maybe the pathology pictures would have been maybe not a great idea. But anyways, you can see this is a frontotemporal dementia where the frontal part of the brain is just completely shrunken up compared to the rest of the brain. Some other non-reversible causes, people who have traumatic brain injuries, Parkinson's type dementia. You can think about Muhammad Ali is a good example of that. Where he just did not, he just not getting better, just continued to progressively worsen. Infectious things like mad cow disease, which thankfully is incredibly rare. You do stumble upon it every now and then. These people usually have significant cognitive issues along with a lot of other problems. And then Huntington's disease, which is thankfully a kind of a rare genetic condition, but again, a disease that continues to progress and drastically affects a person's cognitive abilities. Some of these conditions that can be reversible, and it goes back to the initial workup that we do, why we do lab work and things like that to kind of rule some of these things out. Things like infection, autoimmune issues, vitamin deficiencies can in theory cause it. I have never replaced someone's vitamins and all of a sudden their memory gets better, but again, it's in theory can happen. Medications, sometimes, people come in, I can't remember, and you look at the medicines they're on, like, well, I couldn't remember either, They're on so much medicine, and they may be appropriate medications, but over time, with the accumulation of them, with the aging population, that they're getting the medications that they're on can clearly affect a person's ability to think and can come out as memory issues. Small brain bleeds can at times cause little transient memory issues, and once the blood gets reabsorbed, it can be improved. Normal pressure hydrocephalus is something that does come up quite often. It's basically just an enlarging of the ventricles in the brain. Typically, you see this with memory loss. People usually have difficulty moving their legs. They feel like their feet are stuck to the floor. And a lot of times they'll have incontinence of urine. And so sometimes you can shunt the fluid out of the ventricle and their memory will get a little bit better. That's why I put it kind of under the maybe reversible. So I always get asked, one common thing is, what are the risk factors? What can people do to kind of prevent, or what are the risk factors for dementias? And the biggest risk factors that have been kind of shown are a lot of alcohol use, patients who have very poorly controlled high blood pressure, diabetes. Depression, there's some studies that think that people who get depression later in life are at a higher risk. Again, it always goes back to the question, is the memory loss from the depression or is the memory loss from a dementia? The studies are kind of mixed on that. High estrogen levels and obesity. And so I tell patients, they always ask, what can we do? My sister has this, or dad had Alzheimer's, or what can I do to try and prevent this the best I can? And what I tell them is, if you look at this is, you don't have to be a physician to understand this. If it's heart healthy, it's brain healthy. Okay, the brain's a very vascular structure, and so a lot of these things here, anybody kind of knows they're not good for your heart. High blood pressure, diabetes, bad cholesterol, heavy alcohol use, smoking, obesity, all lead to heart disease. Well, it also affects the brain as well. And so doing these things or correcting these issues and trying to prevent it, prevention is not the right word, but it can clearly delay the onset of it if someone is prone to get a dementing process eventually, okay? So again, this is kind of a pie chart. This is actually not just this is truly representative of a percentage. I don't have the percentage up there, but you can see a vast majority of dementias are Alzheimer's, and then the other types that we talked about briefly make up only a small portion. I showed this picture last year. I think it kind of gives you a little representation of where the term Alzheimer's started from. This is Dr. Alzheimer's here. He was a German psychiatrist and a neuropathologist who actually described the original pathological findings that we still use today. He discovered this back in the early 1900s. This is the first patient here, a German lady. This woman's only 50 years old, and you can tell she looks a lot older than 50. She was in an insane asylum where Dr. Alzheimer's was practicing, and after she died, he did an autopsy on her, looked at the brain, and kind of started describing some of these unusual features that were present in this lady's brain. So that's the first Alzheimer's patient as described as an Alzheimer's disease. So here we go into the symptoms. And again, these symptoms don't always match perfectly for Alzheimer's disease. And so, but it just kind of run through here. Of course, loss of memory, aphasia, which is like a difficulty getting words out, can't understand or can't speak words correctly. Apraxia, so all of a sudden eating becomes a difficulty, getting clothes on, daily hygiene issues become a problem. Delusions, people are out to get them. They become a little paranoid sometimes. They're hypervigilant sometimes of their surroundings. Easily lost, easily confused, especially if they're getting out of their routine. It kind of goes into the next one here, inability to learn a new task. If you try to teach them a new way to get to the store or a new telephone or something like that, they just can't remember how to do it. Loss of judgment and reason. So things that where you would think if you can't afford to go buy 3 new cars this week, and they don't understand, I can do it right now, it's signed the paper, but they don't realize they got to pay for it down the road. So sometimes there's a loss of that insight, loss of reasoning, loss of judgment. Loss of inhibitions, belligerence, they become a little more testy than what they used to. Social withdrawal, they don't want to get out, they don't want to be in an unfamiliar environment, and so where they used to go to church every Sunday, or they would go out and have coffee or whatever with the buddies, they don't want to do it anymore because they become a little scared of getting lost. So they just want their comfort zone. They don't want to leave the comfort zone. Visual hallucinations can happen. Usually happens a little bit later on, but they start seeing things that no one else sees, and this can be quite troublesome, quite problematic, because the hallucinations they have are as real as you and me here talking right now. It's very real. Trying to rationalize with them, trying to talk them out of it is oftentimes futile. You just have to try to protect them, make sure they're not trying to act on the visual hallucinations. So we talked about stages a little bit. I don't get hung up on stages because in the way I look at it, it doesn't really change the way you treat it a lot. Now, I know the Alzheimer's Association, there's a lot of people who really hit on stages, which is okay. There's not like different treatments for different stages, and so that's why I don't really harp on it a lot. But this is kind of a progression. These are not set in stone. There's a range here. But usually early stage, 2 to 4 years in duration. Middle stage will last about anywhere from a few years to a decade sometimes before it actually progresses into the later stage of memory problems. And we're going to talk about what those different stages mean a little bit. I want to hit on mild cognitive impairment. This is a diagnosis that we make quite often. This is something that was really kind of only used about 15, 20 years ago. This is kind of it's been around, of course, forever, but some kind of a new terminology. And these are people who, when you do the neuropsych testing, they're not quite 100% normal. So you can't explain it just on age. They're not quite normal. However, they're still independent, they're still functional, they carry on their day-to-day activities perfectly fine. Okay, so so they don't fit that definition of dementia, where they have memory loss outside of age, and they have a loss of function. They don't have the loss of function. They got the memory loss, but they're still very functional, very independent. Why is it important? The reason is right here, because, and I tell my patients who I diagnose with this, there is a greater risk every year of them going ahead and progressing into an Alzheimer's type dementia. Now, I've got patients who I've been here for 6 years. I got patients I've been following for 6 years with this. They still haven't progressed. And so now I've got patients who have progressed and are into a full-fledged dementia, okay? Why does one person progress into the next? I don't think we know, okay? And I tell patients too, there's nothing you can do to try to prevent from progressing into it. If you have the pathology, you have the pathology. But also too, I think it's kind of nice to know, hey, you're not quite normal, especially if you start noticing signs, noticing problems, we may be moving into a dementing type situation. So that's kind of the important, it's kind of nomenclature a little bit, but also it tells you there is a distinct difference between, you're fine, you're completely normal, or you have Alzheimer's. You're in the middle, and it may not progress, but it may progress as well. There's some people, some literature who states that maybe this actually improves. I don't know. There's people that contradict that too. I don't know what the right answer is. I never tell people that they're absolutely going to improve, because I just don't know. There's no way of knowing. So we're going to talk a little bit the stages that we talked about earlier with the number of years of duration. Early stage, you're just kind of forgetful. Multitasking becomes an issue. You're having to kind of write reminders, little Post-it notes, but you're not to the point where you're losing the Post-it notes yet. So personality changes, so a little more testy than normal. Shows up on the wrong day, wrong time, or just changes in appearance. Someone who used to be very prim and proper all of a sudden is going out to Walmart in sweatpants and a turtleneck, which is just not the way they are. Nothing wrong with doing that, but it's the difference. It's the change, okay? And I see this sometimes in the clinic. Sometimes I get people who come in all, they're very nicely dressed, and, a year later they're coming in and they haven't had a shower in a week, and they're disheveled and their hair's not combed, and I'm like, okay, something's wrong. Some people, they show up like that every day, every time they come to the clinic, which is, again, fine, but it's the change that matters. Again, preference for familiar things. They don't want to get out and kind of explore. Going on vacations, they don't really want to do. They prefer just to stay home, stay in their comfortable environment. Middle stage, they get disoriented. They're starting to get lost in the house. They're walking into the bedroom when they meant to walk into the bathroom, and just kind of some subtle things, but getting a little disoriented with things that should be pretty common, pretty familiar with them. Again, start losing insight, and we're going to come back to this a little bit, and I think there's going to be some other people who kind of hit onto this too, but I'll mention it now so I don't forget it. This is where, unfortunately, you have to start being very careful from a family standpoint. You have to watch for predators. Trying to get him to send money. My grandmother, one of them, some guy from Jamaica keeps calling her. He's such a sweet guy. I don't know how he found out. She's 91, but he found out somehow. And so you have to start watching, kind of making sure transactions and stuff like that are normal, because people do take advantage of these situations. And again, it comes back to insight. They don't realize, if I do this, there's going to be potential consequences or issues on the road. They just don't see that insight. Learning things become difficult. Declining recognitions of acquaintances. So again, they're still recognizing family members, but they may not recognize their cousin they've not seen in 4 or 5 years, or they may not recognize a niece or nephew that they're not all that close to. They know them, but they're not that close to them. All of a sudden, they have difficulty remembering who they are. Again, continued issues with mood, behavioral changes, a little less functional. Alterations in sleep and appetite. And so either sleep patterns, they're wanting to sleep all the time, they're up all night, sleep all day, appetites change. Usually it's more they don't want to eat anything as opposed to wanting to eat everything. It's usually they become, I would say anorexic, but they're kind of moving in that direction. Wandering becomes a big issue. Okay, so they go out for a walk, and all of a sudden they make a wrong turn on the city block, and they don't know how to get back home. So these people wander off, and unfortunately, I believe there was one in the news just a few weeks ago. I don't know the circumstances, but it's a similar situation. Probably went off to take a walk, very familiar environment, place he's probably walked forever, just got lost. And so it does happen, unfortunately. Later stages, severe disorientation in time and place. They don't know what day of the week it is. They don't know where they are. They're in their own home, don't recognize their own house. Basically have no short-term memory. You can tell, they can eat breakfast and in 5 minutes can't tell you what they just had. Loss of speech, or the speech becomes basically incoherent. The sentences that they say make no sense whatsoever. They do begin to have difficulties with walking, so falls become an issue. It's one thing people don't really think about. You do have to have a little bit of cognitive ability to put one foot in front of the other. And so patients who get in this later stage, that becomes a big issue. Loss of bowel and bladder control. They just don't know, hey, I've got the urge, I've got to go to the bathroom. They don't put the fact that they have to go to the bathroom, they just go. Then they start having difficulty recognizing family members. And so family members that have been very close to them, even spouses sometimes, become unrecognizable. Now, the one thing that usually stays intact is they do know who they are. And so that is something that usually stays intact. They do know who they are. But, and basically these folks become total care. These are 24/7 care. They need someone watching them after them all the time. Some more pictures, again, just to kind of give you a big picture. This is a normal brain here, and this is a brain of someone who has Alzheimer's disease. You can see how the brain is shrunken up. It is a degenerative process where the brain tissue does continue to shrinken up, and we're going to look at that. This is just another picture. Again, I'm not trying to make you guys neuropathologists, but you don't have to be one to kind of see the difference here, where you have nice full brain area tissues here, and here you have a lot of atrophy shrinkage. This is the ventricles here where the fluid is located. They get larger as the brain shrinks down. This is just a kind of a schematic, kind of the same thing, which shows a little bit of this is a healthy neuron or a nerve cell here. And here you can see where this amyloid plaque, which is kind of the pathological finding that you see in Alzheimer's disease, begins to attack the brain on a cellular level. You get the deterioration, the degeneration of the brain. And this is just another picture here, kind of breaking down the stages. It's not a great picture, but the only one I could find. But again, you can tell clearly as the grade 1, grade 2, grade 3, kind of the early, moderate, severe that we just talked about, you can see how that clearly progresses pathologically as well. I'm going to show this picture. We're going to come back to this picture just at the end of the talk. This is a PET scan, which we don't do in clinical medicine. This is kind of more, and they're still in the research phase. But this right here is a normal brain here. This is normal, the bright colors here are metabolic activity. So this is the uptake of usually glucose, okay? So this is the brain functioning normal. It's using energy, it's creating energy that the PET scan can pick up. This right here is a patient with Alzheimer's disease, where Alzheimer's disease typically will affect more the parietal lobe of the brain, which is back in these two areas here. And so you can see, again, you don't have to be a radiologist to see this. You can see that clearly the amount of metabolic activity in those areas is significantly declined. And again, this is a true pathology picture of plaques and tangles. And so if you know anything about Alzheimer's, you'll see references to plaques and tangles. This is what it looks like right here. Again, we talked about risk factors a little bit. Let's go back to that just for a second for Alzheimer's disease. Family history. It is something to always consider. And a lot of patients come in and say, well, family members had, my grandma had Alzheimer's, grandpa had Alzheimer's. And I think my next question to them always is, how old were they? Okay. If you really look, clear inherited patterns of Alzheimer's disease really is not all that common. About 10-15% of Alzheimer's are are familial. Usually the patients who develop dementias in the early ages, and I mean early ages, I'm talking early 60s, mid 60s, a lot of times are more prone to be more of a genetic condition as opposed to someone who's getting it in their late 70s, early 80s. So when someone comes in and says, oh, grandpa had Alzheimer's, grandma had Alzheimer's, well, how old were they? Well, they were 80. Well, that's the law of statistics, okay? Because once you hit in the early to mid 80s, the chances of getting a dementia of some type starts really increasing significantly. Okay, so just because you have a family history of it doesn't mean necessarily that you're doomed to get it, especially if the family members are getting it in their 70s and 80s. Now, if you got a long family history of people getting it in their early to mid 60s, then it's a little more worrisome. Is there some type of genetic pattern here? That's not always 100%, but that's typically where you see, because again, the familial pattern becomes a concern. But again, we're talking about something that's very common, and especially the older you get as the population ages, it's going to become more and more common. Just because several family members have it may just be statistics and not necessarily a familial situation, okay? I threw Down syndrome in here because it's interesting. Down syndrome patients, if they live to be in their 40s, almost 100% of them will have dementia. And they have an Alzheimer's type dementia. They look and behave just like an 80-year-old Alzheimer's patient. So Down syndrome is one that will get it very early. I've got 3 or 4 in my clinic, and they're in their mid-40s, late 40s, and all 3 of them have very bad dementia as well. Risk factors, chronic hypertension. Again, it goes back to if it's healthy for the heart, it's healthy for the brain. So treatment, reduction of the blood pressure, reduction of diabetes, blood sugar control, exercise, reduction of obesity, things like that do reduce the risk. It doesn't mean you won't get it. Okay. Head injuries, 3 times more likely to get Alzheimer's. Again, I'll go back to Muhammad Ali, prime example. And these patients, more and more, we're understanding concussion and chronic traumatic encephalopathy. God gave us a skull for a reason. It was protect the brain. And whacking heads and stuff does have consequences, and it usually has cumulative consequences. And so clearly, head injuries, head trauma, of course, sometimes you can't help it, but sometimes you can kind of modify potentially risky behavior and curtail that at least a little bit. Gender, there's some studies who say female is more at risk. There's some studies who say male is more at risk. Who knows? Treatments. I wish I had 10 slides on this. I wish I had tons of stuff we could talk about here. Unfortunately, we don't. Okay? Medications that are used for Alzheimer's disease, this is what I tell my patients, and so if you guys have heard this, forgive the redundance, but it doesn't stop it. So if this is going to continue to progress, the medicines will not stop it. It will not reverse it. It's not going to give you the memory of a 10-year-old, or of a 20-year-old, okay? It does slow progression down, and that's why they get used, okay? So again, it doesn't mean it'll stop progression, doesn't reverse it, but the studies have shown that it does slow progression down. The endpoints in the studies were from independence to dependence. And so patients who were on the medicine stayed independent longer than patients who were not on the medication. We're talking months to maybe a year or so. These medicines are not gangbusters, but they are something. I tell my patients too, you can come here, you can go to Vanderbilt, you can go to Harvard. They're going to do a lot more tests on you. You're going to walk out in the same 2 medicines. I mean, unfortunately, it is just all we have. With the exception of clinical trials. Now, there are clinical trials and stuff that can be done, but as far as routine clinical practice, treatment, medication treatment for Alzheimer's disease, these are it, okay? These 3 medicines here, Aricept, Exelon, galantamine, are in the same class of therapy, so usually patients are on one of these 3. Namenda is another medicine that works on a different chemical pathway. In my opinion, one is not superior to the other. Oftentimes, people are oftentimes on one of these 3 plus Namenda, okay? You'll see advertisements for a drug called Namzaric. All Namzaric is this plus this in one pill. That's all it is. So it's not a brand, they make it sound like it's a brand new fancy medicine. It's not. It's just a combination, okay? And again, slows progression to dependence, does not stop progression or reverse memory loss. Now, one thing I always tell my patients too, again, typically dementia is a slowly progressing disease. This is something that is going to progressively worsen over years. And so if you have issues where all of a sudden they wake up and the confusion is just so much worse. It's usually not the dementia, okay? You have to start looking for usually more medical issues. And so do they have medication issues? Do they have a urinary tract infection? Do they have pneumonia? Are they dehydrated? All these things can cause significant worsening of confusion, especially in patients who already have a tendency to be confused or already demented. It seems that it affects them a lot worse, okay? So my point is, if all of a sudden one day everything's spiraling out of control, it may not be the dementia getting worse. It may be something that's fixable. And so what I mean fixable is antibiotics, fluids, some kind of treatment to try to help with some type of medical issue. And typically patients, not always, but typically patients, once you fix that issue, let's just use, for example, urinary tract infection, which are very common. Once you fix the urinary tract infection, once you complete the course of antibiotics, it may take a while for that brain to kind of catch back up. And so a lot of patients and a lot of families get real antsy because they're not getting back to normal. The antibiotics are done. UTI is treated. Well, yeah, but that brain's 85 years old and it's demented. It's going to take a while for that thing to kind of catch back up. Typically, though, they do get back to their original baseline. Not always, but typically they do. So my point of saying that is, if you see this rapid decline over a day or two, you might want to just start talking to primary care or someone like that and kind of looking for some common medical issues. I kind of list them out there. All right, so the patient who has dementia, how can you try to make their life a little bit better? Okay, we're going to talk about living with dementia from a patient standpoint and then from a caregiver standpoint. One is to keep up with good physical and mental health. You know, go for a walk, exercise, stimulation. If you feel healthy, you do feel better. Okay, and again, if you stay healthy, you can stay away from the flu and the pneumonias and stuff like that. It keeps the confusion from happening and getting worse. Eating healthy, exercise, again, doesn't mean you have to go try to run a 5K, okay? But, just some moderate exercise to try to, get out, kind of get the heart beating, and that does make you feel better. Support groups can help, and like I said, this is a good thing about this issue here. And remember, I showed the millions of people that are dealing with this. There are a lot of people who are going through the exact same thing, and they may have. Sometimes it's just good to talk to someone who knows what you're going through. And that's from a patient and a caregiver standpoint, both. I would tell you, people always tell me, I don't want this person to know. I think it's important that family members know. I think they need to know what's going on. This is kind of my opinion here. I don't think there's any benefit in hiding diagnosis usually, especially in something like this, especially if it's going to be a situation where the family needs to be on the lookout, if you will, if there are issues that are arising and problems happening. Wear identification. Again, if all of a sudden you see someone wandering off, you don't know who they are, have your wallet with you, have a bracelet on them. This is his name, here's a contact number, patient has Alzheimer's disease. That way they know, okay? I always talk about this too, and I know there's some people who are going to kind of talk about this later on. I always tell my patients to have plan B options, okay? Living in a home, fine. But what happens if all of a sudden living in a home doesn't become an option? What do you do next? It's a lot easier to talk about those things when you're not in a crisis situation. And okay, if living in a home doesn't work, or if assisted living doesn't work, what is the next step? Where would we want to go? And kind of start talking with family, planning out, and also too, let the patient determine what they would like. Keep in mind, they may get to the point where they can't really tell you what they want. So my standpoint is you don't have to dwell on it, but it's kind of nice to know, hey, if I get to the point where I can't make decisions for myself, here's what I want you to do. Here's where I would like to go. And that way, if it happens, when it happens, the family knows. It makes it a little bit easier. Caregivers. If, and I stress the word if to the nth degree here, if there is a silver lining in this disease, the patients don't suffer. A lot of times the patients just they don't know. They're oblivious. This is a condition, this is a process, this is a disease that is so much harder on the caregivers than it is the patients, okay? It's very important to be open about that. And I see patients, family members being very, very cavalier and very, and they have good intentions, but I'm like, you have to get help with this. This is and it wears on the family members much, much, much more than it does the patient. And families have very good intentions, excellent intentions, but then all of a sudden the family members are sick. All of a sudden, you instead of having one patient with dementia, you got a patient with dementia, and then you got someone else with, some type of illness or whatever, because they haven't been taking care of themselves, because they've been so involved in taking care of the patient. Don't be afraid to ask for help. Don't be afraid to say, I need help with this, okay? Also, try to be patient whenever you've asked the patient numerous questions. And so, again, they're slower. Give them a chance to kind of respond. Give them a chance, and if they respond something weird, you don't have to jump all over, not that you would, but I'm just saying you don't have to jump all over and try to correct them, okay? Give them a chance to respond. Let them make some decisions. Where do you want to eat? I want to eat, Mexican. I hate Mexican, but take them. Let them feel like that they have some kind of importance or some kind of, just don't tell them to do everything. Let them try to make some decisions, and let them kind of choose what they want to do and such. It can help them. Write out daily activities, okay? Write it out every day. Today you have a doctor's appointment. Today you have church, and that way they have a visual aid to help them remember what they have to do. Again, avoid major changes in home environments. And sometimes this can't be helped, but rearranging the furniture in every room in the house is not a good idea unless you just have no other choice, okay? They will get incredibly confused, okay? And it may take you days to get them back on track, okay? Now, sometimes it can't be helped, but I've had people try to, all of a sudden, we'll put down hardwood floors and throw out this, and the patient is just, it's a task. It's a task to get them to realize what all's happened. Safety measures in the home, trying to avoid stairs, trying to avoid, things that could potentially cause falls. One thing that becomes a big issue is cooking. They put something on the stove, forget it's there. All of a sudden you got a fire, okay? So these things are issues that are common things that happen. Sometimes you have to turn off the gas, or microwave only. Sometimes even the microwave becomes a problem. They put a microwave dinner in there and set it for 20 minutes. Well, you got a problem, okay, and it becomes a safety issue. Again, speak slowly, one idea at a time. Again, they have difficulty with multitasking, being patient, waiting for a response, do things that the patient enjoys doing. Allow extra time to get from point A to point B. They don't like being rushed. They feel rushed, they get confused, they get anxious, can be a problem. Again, this goes back to respite care for the caregiver. Get some help. Take some time off for yourself. Have someone come in and watch the patient while you go shoe shopping or whatever, okay? Make sure you have time for yourself, and don't be afraid to ask for help. Family education. This is you can educate the patient from the beginning, but after a while, the patient's not going to really understand what you're telling them. So it does come down to family education. Regular annual visits to kind of just see how things are going. Allow family members to come in. Usually, the one condition where I have a lot of family members who come to the appointments is this right here, and I think it's good. And I may see them only every 6 months to a year, but they come in. Okay, we're having this issue. We're having this issue. We're having this issue. And this daughter's from Knoxville, and this person's from Indianapolis, but they're all here together to try to get everyone's questions answered at one time and be kind of involved in the care, and that way also make sure that everyone's on the same page. Physical activity, regulated sleep patterns. Short naps are okay. Sleep patterns change. People get all worried when people take naps. Older folks, the sleep patterns change. Sleep cycles change. It's not uncommon, and it's not abnormal to take a little nap every now and then. Now, if they're sleeping 4 hours in the afternoon, that's probably not normal, but a little cat nap here and there is okay. But you want to try to keep sleep patterns regular for the patient. When it's daytime, time to be up. When it's nighttime, time to be asleep. They can get their days and nights turned backwards very quickly, okay? And then, of course, stay hydrated, good diet. Social interactions, mental stimulation. I always get asked too about puzzles and crossword puzzles, and are these things helpful? If you enjoy doing it, do it, okay? I tell patients to try to find something that's intellectually stimulating that you enjoy, okay? Now, don't give me a crossword puzzle because I'd absolutely hate it, okay? But try to find something that's a little more difficult than normal. However, if the patient becomes frustrated with it, drop it, okay? Don't push them to the point of frustration, okay? So like if they enjoy to read, well, maybe read on just a little higher level and see and try to help kind of stimulate that mental health a little bit, okay? The last thing you want to do is just plop down in front of the TV and watch TV all day. That is not healthy. I'm not saying you can't watch TV, but these patients can just sit down in front of the TV, watch TV all day, and then you end up getting depression and stuff like that setting in that just causes more problems. And again, safety, cooking, driving's a big one. Again, they have difficulty not only with slowed reflexes, but they have difficulty with insight. Okay, if I'm doing 80 miles an hour down oil well, that's probably not a good idea. Now, I may not get in trouble, but it's not a good idea, okay? The insight is not there. The reflexes aren't there. Well, I can drive, I get this all the time. Well, I can drive perfectly fine. I can keep the car between the lines. I understand that. But all of a sudden, if someone pulls out in front of you, you got to think about what you have to do next. By that time, you got to wreck, okay? Now, this is a contentious issue a lot of times because it's a big independence thing, especially for men. It's a big independence thing. One thing that we do have available, and I should have checked on this before this, but the state actually had a grant. I think we still have a grant. You can do independent driving evaluations for patients with dementia, okay? Do them here in Jackson. They're done by occupational therapists. That way you have an independent person looking at it. Because a lot of times this is the family versus the patient. The family is saying you can't drive. The patient's like, dadgummit, I dare you to take away my keys. You know, you get someone completely independent to look at it and to see how well are the reflexes, are they safe to drive. One thing to keep in mind, if you do the driving test though, and the patient fails it, they've lost their license. Because of course they can't fail somebody, then you say, well, here's your car keys and let them drive out of the parking lot, okay? But those things are available here in Jackson if that becomes an issue. But the driving's a big one. Driving's a big one. We talk about prevention. I touched on that briefly, staying healthy, keeping your mind active, mind-stimulating situations, hypertension control. Education, I just mentioned this, not that you can go back to college at age 70, but there is some evidence that shows that those people who have a little bit higher level of education seemingly do have kind of a delayed onset of dementia. Healthy diets, a big thing that actually, believe it or not, has got some good studies and good data behind it is the Mediterranean diet. So things high in like fatty, omega-3 fish oils, nuts, olive oil, stuff like that. There's actually some pretty good evidence that it can, not prevent's not the right word, but it can really delay the onset of dementia. Lastly, I'm about done, I promise. Where are we going? Okay, we talked before, therapies are not great, okay? There's been kind of a paradigm shift because before, basically, we were trying to treat patients after they got diagnosed, which just has not worked out well. So what we're really trying to do now, when I say we, I'm talking about the medical community in general, is trying to find patients early in the course, before they're even symptomatic, in their 40s and 50s. Do they already have the pathological changes in the 40s and 50s? They're perfectly functional. They have no symptoms whatsoever. But do they have the pathology findings at that age? And then can you start treating it then, before you ever start having any kind of cognitive issues? This goes back to the PET scans we talked about. PET scans are part of it. There are different types of SPECT scans. There are all kinds of different kinds of radiology where we're trying to find where is, if you start seeing some low metabolism in this area, does that mean you all of a sudden have the potential of developing an Alzheimer's disease 20 years down the road? And then are the medications or something that can be done in the 40s and 50s to try to prevent it from ever even getting to a dependent type dementia. That's kind of the way a lot of the research is kind of looking at right now. And again, this shows that, again, this is actually out of a study here looking. You can tell clearly the PET scan, these areas of the brain here that show complete, lack of metabolic flow in a patient with Alzheimer's disease. And so that's kind of where the future studies, and hopefully someday we may be able to try to hit this and stop this before it even becomes an issue. So to recap, not all memory loss is dementia, okay? There are different types of dementia. Alzheimer's is by far the most common type of dementia. Treatments are unfortunately subpar, but therapies, the main therapies especially, come down to safety of the patient, and also support and care for those that are caring for these patients. I think that's it. That is it. So I'll take some questions if we have time.
Do you feel that it is inappropriate to take a parent out of the home when that is been diagnosed as a problem for them, when we do not feel the other parent can take care of all the needs with the medications and stuff? Is it wrong to take them out of their home?
If they are having issues getting medications confused, if you have issues with, let's just say, for example, you walk into the house and medications are all over the place, clearly medicines aren't being given correctly, the house is in a little bit of disarray, moldy bread. My point is, if it's to the point where there's difficulty with functioning, and so simple activities of daily living are becoming a problem, and there's some safety issues, yes, I think it's appropriate to take them out for the safety not only of the patient but also of the elderly spouse too. Because like I said, I mean, this can and a lot of times patients, the family members don't even realize how bad off they're getting. And before they know it, they're sick, and then you've got two parents that are down. And so, especially if you're having, like I said, if you're having safety issues, if you're noticing medications are getting mixed up, which is a big safety issue, big safety problem, it is not, in my opinion, inappropriate to take someone out of the house and put them in assisted living. Now, it's easy for me to say that. That's a tough thing to do. It's a tough, it's a tough road to go down as a family member. But sometimes you just have to do some tough things for their own good and for the good of the spouse too.
I'm having problems with bathing.
Mm-hmm.
I don't understand why water hurts when I touch my patient with water.
I'm not sure why it would hurt per se. Now, they do have sensitivity. They can develop sensitivity issues, and so all of a sudden lights and stuff like that become more. That's a good question. But again, is the water hurting them? Probably not. Okay. In her brain, I think it's probably, again, it's a little bit of an assumption, but it's probably more of she's scared of something different. Is the water actually physically causing pain? Probably not, okay? But in her mind, the way she conceptualizes, the way it's a different environment. It's a different environment. All of a sudden, she's got something that's a different temperature, different, she's naked, I mean, it's a different dynamic that she just doesn't adjust to. And so it comes out as this hurts me, which is basically saying, stop doing this, which I would not encourage you to do. She needs the bath. But again, as far as you causing physical pain to her, I doubt that's the case.
I've checked her skin, and there's no damage to
Yeah.
her skin. I mean, she's healthy as far as her skin, but she does complain, and I feel like it's her insecurity.
I agree with you. I think it's it's the different dynamics. It's an environment that she's not in all the time, and so her way of trying to get back into that normal, secure, realm is to say this hurts. Well, it's not. I don't think it would be actually physically hurting her.
So actually, I need to try to come up with a way to bathe her that she is more secure
Bathing Without a Battle. There's a resource that you can use that helps you do different techniques to, some of it is covering them more and bathing one part at a time, so they're less afraid or exposed, because that's an instinct.
Yeah, right, because I mean, instinctively, whenever you're unclothed, especially around someone that's not familiar, you're insecure. And so they don't process the fact that you're doing them good. And so I didn't realize that resource was available, but
I don't know the author, but I think if you Google Bathing Without a Battle.
yes, ma'am.
We have, both my parents have some stages of dementia. My mother is worse. We have found that my dad is covering for her, and he's being, they're both just 78 years old, and but they're very stubborn. They won't let us take them out of their house. We have tried that once before. We had all the kids got together, cashed out bonds and everything else to make the house payment, to where, like, we checked their Social Security and all that. We got right down to signing the papers. Mom said no. And Dad's paranoid anytime we go over there and try to help clean the house, because he has to do it all now because she can't.
Right.
So we have a unique problem. Well, probably not unique, but.
Well, I mean, you're right. It's easy for me to say, going back to the first question, yes, I would say if it gets to that point, take them out of the house. That's easy for me to say. And I think this is a situation too, I don't have a good answer for you. I'm gonna be honest with you. But, like you said, you're not the first one who's dealt with this. And I think that's where you're relying upon your support groups and stuff like that. Like, I never heard about Bathing Without a Battle. There you go. You know what I'm saying? So I think that's where you rely upon support groups and stuff and say, hey, how did you deal with this? Well, I had the same problem, and here's what we did. I don't have a good answer for you. I don't have a cookie cutter way of saying, do this and this is going to work out fine. But again, I think that's where you kind of rely upon people who have dealt with this. I mean, I've not dealt with this personally, in your situation, okay? Or in the environment where you're going to take someone out of the home. My grandmother, we put her in a nursing home. She went voluntarily. It was easy, okay? Surprised us all, okay? We thought we were going to have a battle on our hands, but we didn't do it. We didn't have one. So like I said, my personal experience, I've never had to actually, against their will, take them out of the home for their own safety. So how do you go about doing that? How's the best way? I think leaning upon people, maybe even in this room, who have gone through similar situations would be more advantageous than me trying to come up with something.
We're also worried about the car because he is a danger in the car.
Well, there are times, and I tell patients this too, I tell family members this too, if you think it's a danger, take the keys away. I mean, you just have to. And again, I will go back to, I'm not trying to just relate on me, my own grandfather was the same way. He was stubborn, 91 years old, dang it, I can drive. Finally he hit somebody, and he realized, okay, you guys aren't being mean to me. You know what I'm saying? So sometimes you just have to do the tough things, and it's not easy, it's not fun, but a lot of times they'll get over it pretty quickly though. They'll get over it, and they'll move on with their life.
I just kind of wanted to ask, we're kind of in a situation right now where this individual is not receptive to the neurological consultations, testing, that kind of thing. I just wonder, when you meet with patients like that, who may have they have the perception of what their truth is, but it's not reality. How do you help families? Because we feel like if we brought that person, they would just lie or tell what their perception is.
Well,
It's faulty.
yeah, I mean, I've had patients who've stormed out the family tricks them into coming for one reason, then they figure out why they're there and they're out the door. I've had that happen before. Part of it comes down to me knowing a little bit ahead of time, and I try to get a little bit of rapport with them first, and then we kind of just backdoor into memory issues or something like that. And I've had people storm out the door, and bye, I'm not dealing with this. And they walk out, and what can you do? You can't force them to do something that's against their will. I don't know if that answers your question or not, but sometimes it just comes down to kind of letting the physician know what the reason is, that there's an issue, and then you can try to tweak it just a little bit and try to, again, to develop, because I mean, they don't know me from Adam. They've never met me before, you know, and so you try to develop a little bit of rapport with them and then start trying to delve into it. And some people are receptive to it, some are not. Yeah, good question. REM sleep behavior disorder is usually more correlated with Parkinson's, okay? So patients who have REM sleep behavior disorder are not guaranteed to get Parkinson's, but a lot of times it is an indicator that even 20, 30 years down the road that Parkinson's can come on. Dementia can be part of Parkinson's later on in life. So it's usually more associated with Parkinson's, not necessarily with dementia itself. Does that answer your question? Okay, I think there's a line of people waiting here to talk to you as well. So thanks a lot, guys. Appreciate it.
Thank you, Dr. Murray. That was wonderful. A whole lot of stuff, and you boiled it down just about as good as any of us probably have ever heard it in that period of time. So we appreciate you very, very much. I'm Paul Alexander. I work with AmeriCare Senior Living here in West Tennessee. We have several assisted livings in West Tennessee. I know there's even people from Obion County here tonight who know about our Etheridge House there. Here in Jackson, we have Alexandria Place. This is Jennifer Brewer, who is our administrator at Alexandria Place. Later on, you'll meet Kathy Nelson, one of our teammates, who also works in West Tennessee. She'll be in one of the breakout sessions. We appreciate Dr. Murray mentioning assisted living as a possibility. I know there are questions that are often asked about whether or not someone with dementia can be in assisted living. Jennifer and her nurse, Lynn, and our other administrators can meet with a family, meet with your loved one, talk with the physician, and be able to assess whether or not your family member can be in assisted living. There is hope, and it's worth, as I always say, leave no stone unturned. Look everywhere, ask questions, and I know Jennifer and Lynn would be glad to talk with you. We're located at the end of Physicians Drive, turn between Dr. Souter's clinic and West Tennessee Bone and Joint, go all the way to the end of the street. At this time, it's my pleasure to introduce our next speaker, who is Sheila Odom. In 1988, Sheila received her behavioral science BS from Bethel College. In 1996, her Master's of Science in Counseling from Freed-Hardeman. In 2002, she became crisis clinician at Pathways of Jackson. And since 2005, she's been serving as clinical manager for Pathways, Haywood County office. She's worked in the area of mental health for 29 years, and she enjoys working with people and assisting them on the pathway to recovery. She says that other than raising her son, it's been her greatest privilege and challenge to take care of her own grandmother who battled with dementia. Please welcome Sheila Odom.
Good afternoon. Hello. Again, my name is Sheila, and it's a pleasure for me to present to you tonight. You know, when you go through things that are really hard, because taking care of someone who has dementia or Alzheimer's, my mother has multiple sclerosis, which is also another very debilitating illness. And when you're going through the struggle and the stress, you love them, but sometimes you ask yourself, why? Why is this? Why am I having to go through this? And I thought about it when I asked myself that question, when Shelley contacted me about doing this. And I thought about it. I said, well, you know, if I say one thing that helps one person in the group, then what I went through, the experience that I had, was well worth it. So I hope I say something that will be helpful to you tonight. My thing is stress management. They told me it might be a problem with this thing. Shelley. Where'd she go? Stressing me out. Oftentimes when I entitled it, Taking Care of Me, instead of taking care of you. Because as caretakers, we always look outwardly at taking care of someone else. And we very seldom use the word me. And it's very important for you to take care of yourself while you're going through this process. For me, with my grandmother, it was a 4-year process of dealing with this illness. And sometimes I didn't know my own name. You know, I was one of the persons, my son and I, she was very attached to us, and we seemed to be an anchor for her, you know. And her youngest daughter was there with her all the time. But when she would get, you know, a little out of control, and then I would show up after work, and I would say, Grandma, she said, I said, it's time to ride out. Because it was something about riding that made her feel better. And so you have to make these sacrifices, but you do get stressed out because you're only flesh and blood. You're a human being. Dr. Murphy talked about the importance of, as that caregiver, remembering to take care of yourself. You know, you don't want to be like this guy right here. He says, I'm so stressed out. What do I do? One guy says, wallow in self-pity till you can wallow no more. The other says, I scream until you can ice cream no more. Because sometimes that's how you feel. You just want to scream. You start out, you know, you're good, you're ready to go, and you've read all the books, and you know what to do, and then days turn into weeks, weeks turn into months, and it starts to wear on you. And that's just the truth. Why does this keep going backwards? Maybe because I keep hitting the wrong one. So, how do you know when you're stressed? Because, you know, I always heard this analogy about a frog in tempered water. If you put the frog in tempered water, you know, he'll sit, you know, if you throw him in boiling water, he'll hop out. But if you set that frog in tempered water, you know, he'll adjust. You turn the temperature up a little bit more, and he'll adjust. And that frog will sit there until he boils himself to death. The same thing with us and stress. You can just simply get used to the pressure, get used to the stress, and your body starts adjusting. If any of you have high blood pressure or know someone who does, they were perfectly fine. They went to the doctor, and their blood pressure was at stroke level. And they said, I didn't know because I was feeling what? Feeling fine. That we adjust to it. So it's really important that you begin to recognize the symptoms of when you're stressed. Because as a caretaker, you're so concentrated on what the person that your loved one is going through. And you forget to take a look at you. So, no pun intended, but memory loss. When you start to not be able to think of the things that you need to do. And because stress puts a strain on your body, and you'll get to where sometimes you can't think of anything. That can be a sign of stress. You can get dizziness, chest pain. Sometimes that's a result of just anxiety, because sometimes you just don't know one day to the next what to expect from your loved one with what they're going through. Your own loss of interest in daily activities. You know, you kind of start to forget yourself, who you are, what you enjoy. Be careful if you notice your jaws where you just kind of grinding your teeth because you're always at hyper state all the time. Got to do this, got to do that, got to do this, got to do that. And you start to notice your jaws are starting to feel a little sore and tight. That's a sign of stress. Headaches, irritation, you get grouchy. Does anybody understand what I'm talking about? Yeah. All right. That those are your warning signs that you are becoming stressed. That it's beginning to get to you. Because again, you have to remember you're only flesh and blood. Not only are you taking care of this family member, but you also know the people in the Lee family. He says, the Lee family has been really stressing me out. Perhaps you know them emotionally, mentally, physically, and let's not forget financially. Because when you're taking care of other people, your life is going on, is it not? You still have family. Some of you still have work responsibilities, spouses. Your life is going on. This is added to it. This is me without hair dye. After the 4 years, I said, Miss Clairol, help me. It says, why, yes, I'm stressed. Why do you ask, you know? Come on. Balance. One of the keys, because they told me I got 10 minutes, so I'm going to make this quick. Balance is important. Now, you got life, you've got work. What is the most, I gave you a clue, which is the most important in this life? Somebody said life. Life. Who said you? There you go. You, because the person in the middle, you're the one that's trying to make all this work, trying to find a way to do it. And you'll put all of these efforts into this thing we call life, our family, career, our health, friends. We've got to find a way to balance all of these areas in our life. And when we don't, you go to either one side or the other side. Then it gets hard to know whether you're coming or what? Or going. There you go. The key is trying to find balance. You can't do it all. If you find a way, what I want you to do is write a book. I don't want any of the proceeds, but I want to go on Oprah with you. I want to be sitting in the front, okay? You have to remember that you are an individual. You consist of 3 components, and you have to find a way to balance yourself, your body, your mind, and your spirit. Before we talked about, Dr. Murphy talked about a lot of physical manifestations of stress, the headaches, poor sleep, appetite. Did you get confused as to whether he was talking about the patient or the caregiver? Okay? Because what's going on in our mind is going to have a manifestation in our body. Even down to skin issues. It's going to show up. Balance. How do I take care of all these parts of myself? My spirit. You know, taking care of my grandmother was a great spiritual walk for me, because I found myself in over my head a lot and talked to a lot of people. But there were some things that I had to rely on a power greater than myself to help me to get through it. But to make sure you're feeding that part of who you are as well. Keep calm and just breathe. Makes it sound simple, doesn't it? Anxiety, stress, it'll cause you to hold your breath. Something happens, we go. We get mad, we go. Breath is what? Breath is life. You got to breathe. I'll tell you a secret. Some people think smoking cigarettes help them to calm down, but it doesn't. Don't be pointing at Tina. Nicotine is a stimulant, right? So this stimulant is calming me down, right? I don't know. How about the breath you take? If you're a smoker or seen a smoker, I used to be a smoker, they take that first pull, they take a deep what? Breath, they hold it, and then they blow it out really, really what? Slow. And when you blow it out, you feel stress and tension moving from your shoulders, your hands, your arms. So what I would like for you to do is just to take a deep breath. Right now, just humor me. In through your nose, hold it, and blow it out through your mouth like you're blowing out a candle. If you're a smoker, you know exactly what I'm talking about. Ready? Come on. Deep breath. Hold it. Release it. One more time. Deep breath. Hold it. Release. How does it feel? Did some of you notice you were tight and didn't even realize it? I might not have time to go to the gym. I found out today from Dr. Murphy, I got a risk factor working here. But you can take time to sometimes just slow down and just breathe. Catch your breath. It's okay. Breath is life. Always remember that. Breath is life. Okay? Rest and self-care are so important. Rest and self-care. It says when you take time to replenish your spirit, it allows you to serve others from the overflow. You cannot serve from an empty vessel. You cannot do it. You'll give and give and give until you are completely and totally given out. And when you give out, what do you have left to give? Nothing. So as being the caretaker plays a very, very important role. So it's important that the caretaker takes care of the caretaker. Now, you know it's bad when the person you're taking care of says, honey, you need some rest. Okay? So remember that. Sometimes we'll feel guilty. But like I told Tina, what's love got to do with that? Okay? The body needs to be able to rest. It's okay. Because tomorrow is another day, is it not? And sometimes with Alzheimer's patients, I know it was with my grandmother, you have to kind of learn to sleep when they sleep sometime. Because my grandma would get away from you. She was a wanderer, okay? And so one day I got over there after work, and boy, she was trying to go home. She was already at home. She didn't know, I don't know who these people are. I want to go home. I'm like, well, Grandma, okay, just calm down. We'll go take a ride. We went and took a ride. We came back. Grandma said, this is not my house. I'm like, Grandma, yes, it is your house. She's like, no, it's not. I said, well, Grandma, let's just come in and see what everybody's doing. She says, okay. And so she was really rowdy. Well, Dr. Twilla told me to give her some Ativan to kind of help slow her down. She wouldn't take it, so I took it. I was like, oh. Woo. I can laugh now, but at the time I just wanted to cry. But that was some good rest. I'm just kidding. I'm teasing. But just remember that it's okay. Give yourself permission to take care of yourself. Okay? How am I doing on time? Stress management tips, as Dr. Murray already talked about, make some little changes in your life can really add up to some big feeling of relief. Just do something. So you're taking care of folks, and now you can't go on a 4-day cruise to Jamaica, okay? It's a wonder storm didn't blow them away anyway. But you can't do that. But you can do little things, like taking a walk if you used to like to walk. Doing some knitting, whatever it was you like to do, try to add back some normalcy to your own life when you're in this caretaker process. Learn to recognize when you are feeling stressed as simple ways that you can relax. You have to do that for yourself. But he told you no smoking, no drinking, so I guess you got to find something else to do. You want to stay positive, stay positive. Help friends and family cope with stress. Y'all, I'll tell you something else. Let me hurry up. I hear the clock ticking. Sometimes when you're the primary caretaker, other people and families want to come in and tell you what to do and what you shouldn't be doing and what you ought to be doing. They read a couple of books, go to a few seminars, and then they're going to come in and tell you what you need to be doing. Okay? And you got to figure out how you're going to deal with that in yourself. And how you're going to keep from becoming negative, bitter, and angry. That's part of taking care of yourself too. They mean well. They may be not going to do anything to help. But they do mean well. and making sure you find ways to cope with the stress that works for you. Make sure you let other people know that you're overwhelmed. It's okay to ask for help. Those folks that read all those books, they're real good people to ask for help. They know what to do. Let them give you a little bit of break. Use some of the services that they were talking about, resources out there that are available to come in to give you a break. If it's a couple of hours that someone else can come in and assist, don't sit there and assist the assistant. You go for a walk or take a nap, but make sure you do what you need to do. Allow yourself to simply say no. Because sometimes people, that's so great. You're taking care of your mom, you're taking care of your dad, and then they turn around and ask you to do something. Okay? But it's okay to say no. Don't overload your plate because it's full enough. But those are some good stress management tips. Make sure you do some stuff you enjoy. I like this one. Laughter. Make sure you laugh a little bit. It's okay. Laughter is like a medicine. It's a form of stress relief. You say, well, Sheila, there's nothing funny about this situation. I didn't say it was, but you could find a good comedy on TV sometime. Netflix, Hulu. Do something. Read a book. Find something that brings back some humor. This one is, we talked about exercise and meditation, but make sure you cry your required tears. Sometimes we try to be so strong, but it breaks our heart too. And if Jesus could cry, I can cry. Because sometimes that's what you just need to do. Because it just hurts watching a loved one look you in the face and not recognize who you are. Right? So make sure tears have a way of cleansing, relieving pressure on the inside. Do some dancing. I don't too much recommend a trampoline. So if you do it and hurt yourself, don't. It's not my fault. Affirmations, gyms, exercising. Just do something that helps you feel good. Here at West Tennessee Healthcare, we practice a thing called AIDIC. It's a customer service process. And I hope they don't come down and, come down on the ceiling to get me, because I really didn't get permission to use this, but don't tell nobody, okay? But I came up with this AIDIC for self-care. All right, those of you with a badge on like me, shh, okay? I'm broke, they sue me, they're not going to get nothing. But anyway, when you're a caretaker, make sure A is acknowledge. Make sure you acknowledge yourself. Don't lose sight of who you are. Make sure you value yourself. Because guess what? Just like you value other people, if you value yourself, you'll take better care of yourself. So make sure you remember to acknowledge. Is introduce. Make sure you introduce yourself to yourself. See, because you may be in a position where you never thought you would be in. I didn't, and it changed me. It changed me. It was a life-changing event. And I had to stay in touch with where am I, who am I, and what am I doing to keep myself focused. D, duration. Listen, you've got to remember to take life one day at a time. You got to just be in the moment. Because however you're feeling right now is going to have a lot to do with how you project tomorrow. And if your loved one is having a bad day today, you're going to be telling yourself the rest of it's going to be a bad day too. So try to stay in the moment. I had a lot of good memories with my grandmother going through the process, and I enjoyed it, and they're with me just like the bad ones. But if you'll just take life one day at a time. E, explanation. Know why you're doing what you're doing. Know why you're doing what you're doing. Remember what motivates you to do what you're doing. Okay? I say that when, especially with asking people for help. And sometimes when family members and stuff come in and you need some help and you know you need some help, but you're being stubborn. Just thought I'd throw that in. Didn't cost you nothing. But why am I doing what I'm doing? Allow that help. 5 is, number T is thank you. Make sure you appreciate yourself. Your loved one loves you so dearly, but they may get to a point where they can't tell you thank you anymore. So make sure you appreciate yourself. Take good care of yourself. That's the aided of self-care. I may have a copy written. And when all else fails and you try to do all these things, we're very familiar with the serenity prayer. God grant me the serenity to accept the things that I cannot change, the courage to change the things that I can, and the wisdom to know the difference. We say it, we quote it, we got it hanging on our wall, but when you're in a caretaking role, you got to learn how to live it. And it will help you walk that out. Now, if you notice, it's a little bit longer. This is the full serenity prayer. This is top part is what you usually see at Kirkland's. But this other part, the other part of that serenity prayer says, living one day at a time, enjoying one moment at a time, accepting that hardships as a pathway to peace, taking as Jesus did the sinful world as it is, not as I would have it to be, trusting that you will make all things right if I surrender to your will, so that I may be reasonably happy in this life and supremely happy with you forever in the next. That is the serenity prayer in its entirety. And you can find that on Google. But you have to remember that. Serenity is some peace. And you have to maintain your peace of mind. Remembering what you can't help, just like remembering what they cannot help. And I hope some of you went, oh, okay, I get it, when Dr. Murphy was talking, that they weren't being oppositional. They just simply couldn't what? Couldn't help it. All right. So that serenity prayer, it has helped me get through a whole lot of things in my life. It's been around a long time, so it must be something good about it. So in closing, just remember, you can do anything. You can do anything. You are an outstanding, dynamic individual, but you can't do everything. And there's nothing wrong with acknowledging that. Allow someone to help you through this part of your journey. Focusing on taking care of others, but don't forget to take care of who? 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 One more time. All right. Thank you for your time. I'm noisy.
Thank you, Sheila Odom. That was great. Okay, I am Pam Wright. I'm an elder law attorney here in Jackson, and I depend a great deal on the hospital and the senior services and the Alzheimer's community to help myself and my clients. Like many of the speakers that you hear tonight, I'm also a former family caregiver. And it's my pleasure to let you know what the rest of the evening has to offer. In just a minute, we're going to take a break. There's still food out in the entry. If you want to get a snack, visit the vendors and their booths. Take some time to get that information. And then we're going to have these breakout sessions, which will be just as good as the programs has been already. For the first section, you have a choice between legal and financial decisions and living and care options. Legal and financial decisions, the speaker is Laura Williams, one of my favorite legal speakers, who's a member of the law firm of Rainey, Kaiser, Revere, and Bell here in Jackson. And over the 32 years that she has practiced with them, she's worked in every area of the law that would be relevant for caregivers and families. Living and care options is going to be two people talking to you, Leslie Bibb, who operates Comfort Keepers, and Brian McQuiston, who operates Home Instead Senior Care. Both of these are a certain type of care services that are provided in the home, but they are both knowledgeable of all the array of services and can answer a great deal of questions. They're both highly experienced in this area. Leslie, I want to point out, is our representative to the Tennessee Commission on Aging and Disability for this region. So they bring a great deal of expertise. Then in our second session, when the first session ends, you don't have to come back in here, just go on to the next session that you choose. It's going to be either medication information or the roundtable discussion. Medication information, the speaker is going to be Nancy Tucker, who is a pharmacist here in this hospital and has a great deal of experience. And like there's so many of us that are speakers who are presently caregivers or have been caregivers. So Nancy also has that experience to bring to the discussion. The round table, we're going to have Karen Grace and Kathy Nelson, both of whom are active with the Alzheimer's community work. Kathy is the Regional Elder Care Advisor with AmeriCare Senior Living. She has a great deal of experience with assisted living and memory care options in the region. And Karen Grace has been in healthcare for 42 years. She's worked with the State Department of Health, Jackson Clinic, Blue Cross Blue Shield, and now she's administrator of the arthritis clinic. So all of our speakers have a wide array of experience and can bring you some great information. So let's don't waste any time. Let's get that break and get on with the next part of the program. Thank y'all.